So, looking through this case, our 6-year-old Labrador Retriever, subtle personality change, 2 episodes with left facial twitching, chewing movements around 60, 90 seconds, progressed to generalized tonic-clonic activity, disoriented for about 20 minutes afterwards. On neuroexam, ambulatory mild proprioceptive ataxia tends to circle right when moving freely, pulse reaction delayed in left thoracics. Menace is reduced on the left. PLRs are normal. Ocular position is normal. No nystagmus. Facial sensation palpebral are symmetric. Gag is normal. Tongue strength is symmetric, and hearing appears intact. Let me tell you. So the reason I write these this way, because you're probably like, why the heck is this jerk giving us all of this extraneous information? One, it helps you critically evaluate what's normal, what's important, right? Because something being normal and stating something is normal is just as important as stating something is abnormal. And as you guys go into your careers, when it comes to neurological defects, put in there cranial nerves tested and we're all normal. Because I'll tell you, I've done it before. You put in there and you're like, did I actually look at it? I'm assuming I did because I know how I practice, but by golly, there are just days you're like, man, now the cranial nerve is abnormal. Did I miss it? Did I not test it? And that's why I don't use any form functions for my neuroexam. I actually type out my neuroexam very similar to this in the medical record. I don't use a form because I don't want there to be, what we all see, right? Dog comes in, clearly severely neurologic. What is the medical record? No neurological deficits identified or neuroexam not performed. You're like, bad idea. All right. So, looking at this case, where would you all localize it? Be as specific as possible. And so, right-sided, cerebrothalamic, you will also hear right-sided forebrain. Now, remember that forebrain is broken down into the cerebrum and the diencephalon or the thalamus, right? And so that is one thing that people sometimes forget. And the reason that a lot of people who tend to be very specific and detailed will say cerebrothalamic or the telencephalon and diencephalon. But forebrain encompasses all of that because a lot of people forget that the diencephalon actually is this weird no man's land of confusion. So, but this is right, cerebrothalamic. This is a great case that is a nice low hanging fruit for general board type stuff of saying, okay, can you do the basics, right? Do you recognize that seizures are always going to be in the forebrain, that cerebrothalamic region? Are you going to have contralateral proprioceptive deficits? Are you sure that everything's making sense? Are you going to have that menace that is on the contralateral side from the eye in which you're testing? Now, menace response, we talked about this last time we met. It's, we generalize it, but it could be a little bit more specific. And so you do have to, again, when you're testing it, try to be a little bit more on the lateral side. Um, The other thing that wasn't reported in this that could be abnormal would be nasal sensation. Remember that nasal sensation is absolutely going to be 5 to feel, contralateral brain to respond. And when we test nasal sensation, again, I don't care about is this a dramatic response or is this a calm dull? And they don't care because they're a 12-year-old lab. What I care is does the left match the right? That's more important to me than the degree of response. Perfect. And then everything else was basically here to tell you it ain't brainstem, brother. Move on. Are there questions regarding any finding in here and how this fits into the clinical signs? Right. And these episodes are going to be kind of these non-convulsive seizures, again, depending on how you classify things. You could say that this is a partial seizure, borderline absent seizure, though technically those require an EEG to be diagnosed. So But you could say partial type seizure going into generalized. So partial to generalized is how I would classify this clearly seizing dog. So any questions on this localization? Try to start you out with something not too wild. All right. So case number two, our sentiment was a 3-year-old female standard poodle, 20 kgs, 2 weeks for lesson to rise, and yelping with the owner described as wobbly walking, worse in the morning and after rest, decreased appetite at home, no seizure activity, no toxin exposure. Mentation is normal. Gait is short strided, stiff, and guarded with reluctance to bear full weight. Resist mal resist manipulation of multiple joints. When supported to minimize discomfort, she does not demonstrate truncal sway, knuckling, scuffing, or true proprioceptive ataxia. Pulsar reactions, and you will hear me say pulsar reactions. You will not hear me say conscious proprioception. Conscious proprioception cannot be tested separate from unconscious, so the term CPs is technically incorrect. See, I also am pedantic, so but not, I like to be in the middle. Posture reactions were normal. All right. Spinal reflexes were normal. Cranial nerve exam is normal. And pain is present on spinal limb palpation. So, how did you guys localize this dog? Aha. Yes. So, this one hopefully was a bit of a thinker for you because there's a lot here that says, by golly, this dog ain't neurologic. And I think the hardest thing in any case, right, is to say it's not something, right? Um, and one could argue that if you were going to neurolocalize it, if you put this in as a motor unit disorder or a lower motor neuron disorder, I think you would be okay in that category because a lot of our conditions look like that. But the one thing that makes it not lower motor neuron is those are not painful diseases. Maybe polyradic has a little bit of discomfort, but not in a way that like why are the limbs painful, right? And so hopefully you were more like, wow, this kind of sounds like an IMPA case. Because it is. Now, are they likely to give you a case like this and say neurolocalize it and it not be neuro? No. But I hope that you sat there with this one and was like, I don't get it. Um, or was like, ooh, I don't think this case is really neuro, right? And that really, for me, highlights that what we have is a dog that doesn't demonstrate proprioceptive abnormalities. And that is one of our more sensitive tests. It doesn't mean much localization wise, but it does tell us that the nervous system is probably involved or that we have enough weakness or biomechanical abnormalities that the limb doesn't flip. But if you're doing your neurological exam well and you're supporting that pelvis whilst you're testing your limbs and you're supporting the chest and not letting the dog fall and you're taking the weight from them, then you should still get flipping, even if it is a weakness, even if it is some sort of orthopedic condition, or at least you get the sense that dog knows that that paw ain't right and it's trying to move it. So, yeah, that one we went from easy to like not even on the neurologic spectrum because I'm a jerk. All right, case number three. 4-year-old male neutered Australian Shepherd, sudden rolling onset of imbalance after vigorous play in the evening, no witness trauma, no known access to marijuana, vomited once during episode. Between episode, the owner feels he's stressed. So bright and appropriate, ambulatory with a wide base stance, truncal sway, drifting and falling to the right with a right-sided head toe. Nystagmus is not present at rest, though mild positional nystagmus can be provoked. Postural reactions are subtle but consistently delayed on the left limbs and normal on the right. Menace is present OU. Pupillary light reflexes are normal OU. Ocular position's boring. All the facial stuff's kind of boring. All the, spinal reflexes were normal. No pain here. So, can you be more specific? So, is this classic central or is this paradoxical? Because again, technically, right, your workflow should go peripheral versus central, and then central is either classic central or paradoxical. Yeah. So this one's paradoxical. Remember that when it comes to proprioceptive abnormalities, they are your only friend in vestibular disease. Everyone else will lie to you, will break your heart, will tell you sweet nothings and whisper in your ear and give you a kiss goodbye and then go and lie to you. All right. And so proprioceptive abnormalities, they are always going to be ipsilateral to a vestibular lesion. This is not saying that they are always going to be ipsilateral to a lesion, but they should always be ipsilateral to their or to their vestibular lesion, because that whole vestibular system is caudal to where everything crosses. And so the big takeaway from this is hopefully you definitely saw the drifting and falling to the right with a right-sided head tilt. All right. When we have a case like this, and then we have proprioceptive deficits, absolutely we're in the central nervous system, 100%. So then we have to say, okay, is this classic central or is this paradoxical? And the only difference comes down to, does this match this? And once we say that this is right and this is left, that is in essence the paradox that we're talking about. They don't go together, right? It's like, wait, that's right, that's left. Those should not go together. They are creating a paradox where both technically shouldn't be able to exist. But because the cerebellum is providing inhibitory input to our vestibular nuclei, what happens is that these vestibular nuclei, when the cerebellum is damaged, instead of decreasing their signal, which often happens with central vestibular classic and outer ear disease, peripheral disease, that signal's decreased. But when it comes to cerebellar damage, or specifically that floccular nodular lobe or the caudal peduncle, or depending on how you look at some of the literature of the nuclei, when the cerebellum components are damaged, what that does is it damages the inhibitory component to the vestibular nuclei. So again, instead of that signal going quiet, that signal gets louder and higher. And so the body actually gets confused and thinks the other side is weaker compared to this now stronger side, because the cerebellum is lost its inhibition on the vestibular nuclei. And so that's what creates the paradox. The easy way to go about this that I often tell students is like, step one, is it vestibular? If yes, is it peripheral or is it central? And what you're looking for is all those centralizing signs, right? Proprioceptive deficits, you're looking for changing nystagmus, horizontal nystagmus, cranial nerves other than 7 and 8, right? 7 and 8 get a pass because 7 runs right there under that ear canal. 8 is the vestibular system, right? With peripheral, though, it should be just pure vestibular abnormalities. Um, Especially as you get into some of those peripheral conditions like um, idiopathic vestibular disease and things like that. Um, and then other cranial nerves like 9, 10, 11, 12, those are all great signs that it is a centralized lesion. Remember that all central lesions are brainstem lesions, but not all brainstem lesions are central vestibular lesions. And so you can have brainstem lesions that don't show vestibular signs, but everything that is a classic central vestibular disease is a brainstem disease. And so sometimes people kind of like, wait, what? Oh, that makes a lot of sense now. So kind of keep that in mind. But yeah, so this was a left-sided. So always look and say, okay, I got a vestibular case. So my answer has to match any proprioceptive deficits that may be possible. Great little cheat for taking a test, right? Is like, okay, left limbs are affected on proprioception. So my vestibular lesion only works for vestibular disease, has to be on the same side when we're dealing left versus right. Any questions on this one? One thing that throws people off is you don't have to have cerebellar signs when you have paradoxical vestibular disease. Most of the time it's cerebellar, though there are some exceptions to that rule. where there are other things that could cause paradoxical. But 9 times out of 10, I would say that they're cerebellar. Any questions on that one? Hearing none. Oh, so they asked dogs with central vestibular compared to peripheral look in general more sick clinically wise. This gets a little tough to answer. And everyone loves the answer it depends, right? Because it depends on severity. And the reason that they say that sometimes these central animals look sicker is because you have proprioceptive deficits, you have maybe mentation change if you're involving that ascending reticular activating system. And so maybe they can look a little bit worse. Again, what is the underlying disease process? This is more likely to be a tumor, more likely to be meningoencephalitis. Um, could be an infection with invasion in centrally. And so, like, it depends on how you look at it because, again, there are conditions that can be worse, but right, we can also get neoplasia. We can also get nasty infections peripherally. And so I don't know that I would be like, oh, that dog is really crazy affected because I've seen some nasty idiopathic vestibular disease dogs come in who looked like their entire world was wrecked because they were so severely affected. And so I'd be a little cautious saying, oh, that dog's severely affected, so it has to be central or paradoxical. I mean, some of the paradoxical ones look like pretzels when they come in. And so I don't know that I would necessarily use that like severity of, oh, they're clinically unhealthy. Now, if they're more mentally out of it, I think that supports it. But we say that mentation doesn't change with peripheral, but I think anxiety increases with peripheral. And I think that makes it really, really hard to say, ooh, what am I dealing with? Am I dealing with a dog who is disoriented or a dog who has decreased awareness and arousal in terms of consciousness? And so that's where it gets a little tricky. Um, but again, when I think peripheral versus central, you're looking for those supporting centralized signs. So changing nystagmus, changes in mentation. Again, you can be, we're talking like degree of consciousness, like are they stuporous, are they comatose, proprioceptive deficits, or other cranial nerves. Those are more foundational signs of central. And again, a mild central vestibular dog who had a stroke to the brain stem may not be as severely clinical affected, right? But again, the underlying etiologies, depending on how you look at it and how you talk about it, they certainly raise the likelihood that these animals are more they have maybe more serious diseases because we're dealing with compression of the brainstem from a tumor, or we're dealing with infiltrative disease, right? And so I think it all depends on how you look at it. But hopefully that answers that and provides some context to that question. That's a good question though, because you're not the first to have asked that or kind of said, "Hey, well, does this make sense?" Because again, I think sometimes these peripheral dogs come in looking wrecked. Any other questions? I've had a few dogs like this one that came in with a small vascular event, or they had a vascular event, and by the time they came back and their cerebellum was happier, by the time they came and saw me, they were up doing better. And so timing is also always great, right? They're always going to be worse right when it happens, and not as bad as we get closer to them feeling better, or within a week even. All right, next one. So 8-year-old Doberman Pinscher, 6 months of progressive ataxia, most obvious in the pelvic limbs. Worse on slick floors, turning, yelping when jumping into the car. No seizures, no systemic illness. Neuroexam in paragraph form. Mentation is normal. Ambulatory with tetraparesis, proprioceptive ataxia with pelvic limbs more affected than those in the thoracic limbs, and occasional scuffing during turns. Her thoracic limbs appear to be short strided. Pulse reactions are delayed in all four. Cranial nerve exam is normal, including menace, pupillary lights, systemic facial sensation. Spinal reflexes are normal to increase in the pelvic, with increased extensor tone most evident in the pelvic limbs. There is decreased withdrawals in thoracic limbs. Limb tone appears normal and mild cervical discomfort. Where would we localize our Dobie friend to? Right. So we have both C1, C6, T2 in the chat. I would put this one at a C6, T2. And where is all the drawing tools? There it is. So where's my pen? Oh, that is for. Oh, I see what it's doing. Okay. 1 second. Oh, I can't annotate in this. That's sad. So, when we look at cases of neurological spinal lesions and like, okay, clearly the brain's not involved, right? The easiest thing to do is say, okay, is this neck? Is this back? And this is kind of a simplistic approach, right? Is it neck because it's all four limbs? Or is it back because it's just the back limbs? And of course, you have to be watching out for Shift Sherrington, right? That's an exception that can throw you. And then the only difference between a high cervical and a high back lesion, which are typically going to be associated with upper motor neuron signs of dysfunction, versus a lower neck or lower back is reflexes. And so, in order to subdivide the neck into two sections, C1, C5, C6, T2, the only difference we really care about or look at is going to be reflexes. And in this case, there is a decrease in withdrawals in the thoracic limbs. And so, what that tells me is that those lower motor neurons that cultivate the reflexes have to be involved. And so that puts us at that C6T2. Now, a lot of times with C6T2, you may also see rapid atrophy. You may, if it's a caudal lesion, also see a loss of cutaneous trunci because C8 to T2 is where those lower motor neurons live to facilitate the cutaneous trunci. And you may see a decrease in tone. Reflexes are going to be more sensitive than tone, in my experience. You only need one or the other to put you into this. And a lot of times they go together. But I wanted a dog who was probably painful. And a lot of the pain wolves, animals, when you're manipulating them, they'll actually increase their tone a little bit because they're running on pain. And so they're a little bit more stiff, they're a little bit more uncomfortable. And so it gives this presence that maybe the tone is a little bit increased because they're kind of creating some overdrive or what muscle function. Again, because this dog is not completely paralyzed, right? And so he has tone. And so he can just be adding more voluntarily. Or it's just normal, and that's okay. That tone, again, it's not a catch-all, right? It's what degree of the animals involved, right? If I only have one side or one segment of the spinal cord, I still have like five other segments providing tone to the limb. Whereas maybe that one location really affects the withdrawal reflex, right? So that this animal can't pull it up, but the tone, there's plenty of other guys providing the tone, right? And that's probably what's happening in this particular case. And so when we look at, again, high cervical C1, C5, C6, T2, we're looking for the reflexes. C1, C5 should have normal reflexes and tone, and C6T2 should have abnormal reflexes and tone. And since the reflexes are decreased, that puts us at C6 to T2. And again, the other big thing you can see with C6T2, especially if it's a caudal lesion, not so much if it's like there at C6, C7, but if it's there caudal, like T1, T2, you can also potentially see Horner's as that sympathetic pathway is coming out and leaving that region of the spine. And this would be a great case of a dog with disc-associated cervical spondylomyelopathy. The other thing that puts us lower into the C62 was the short strided gait. Short striated gait is a classic presentation of kind of these lower motor neuron scuffing gaits. And so when you see this like lower motor neuron, like short striated gait times four, now you think lower motor neuron disease. You see reflexes in both the thoracic and the pelvic limb. A single solitary spinal lesion cannot create abnormalities in both the thoracic and the pelvic limbs at the same time. Not a single lesion. What you have to do is either have a diffuse, meaning that entire cord is ablated, such as with like myelomalacia, or a multifocal, such as with myelitis or meningomyelitis, or you have to have a lower motor neuron. And lower motor neuron often makes the most sense because it's the easiest to get of those three, right? Especially if they're presenting normal, because usually myelomalacia, we've watched this dog go downhill over a couple days. Um, and so again, put the whole clinical presentation together. Questions on case 4 are Doberman. Case 5. So we have 2 week worsening right forelimb lameness progressed to intermittent knuckling. It's a 12-year-old cocker. Mentation is normal ambulatory, but weakness in both thoracic limbs. When knuckling, seen bilateral in both thoracic limbs. The pelvic limbs appear to have a stronger gait and ambulate well when the thoracic and chest is supported. Posture reactions are mildly delayed in the left thoracic limb and absent in the right thoracic limb. Both pelvic limbs have normal proprioception. Cranial nerve exam is normal. Munus, pupillary, all of that stuff. Spinal reflexes are decreased withdrawal and decreased triceps within the thoracic limbs. Pelvic limb patellar reflexes are normal bilaterally with intact withdrawal. Cutaneous trunci is difficult to elicit, no spinal pain. Where would you localize this lesion to? Again, be as specific as possible. All right. So yeah, so Emma's putting it back kind of up there, maybe in that little bit more caudal region of C62, but this is definitely a C62. And I would say that the more specific component is that this is affecting the gray matter. So this is a great example of what we call central cord syndrome. So central cord syndrome is when the gray matter that innervates the limbs in the thoracic limb are affected, but the white matter tracks, those upper motor neuron axons that are traveling through the cervical region, are unaffected. The reasons that we see gray matter be affected more than white matter is going to be vascular disease that hits the gray matter. It might be a very centrally located disc that is just pushing up on the core of the spinal cord. And so that the fulcrum of pressure is there more in the gray matter, or cancer. That's a big one. Dachshunds can have central cord syndrome with discs, but usually when I get a large breed dog with central cord, I'm thinking cancer. And so again, central cord syndrome, this is one of those unique scenarios where the neuroexam doesn't fit the classic schematics. It is still a C6D2 lesion. It's just that it's specifically affecting the gray matter, allowing all of those white matter axons that are traveling through the cervical region to get to the back legs. They are spared, they are not damaged, thus allowing signal to get through the cervical region to the back legs, and that's why the back legs are still functioning and working. Questions on this little unique case? Okay. And then we'll go to case six. And again, even if you're like been sitting on a question at any point throughout this, feel free to just throw it in there at any point. Case six, 5-year-old Beagle. 10 days ago, developed intermittent reluctance to jump, occasional yelping when picked up. Owner said she got back pain. Over the last 48 hours, she became progressively weak in the pelvic limbs, now struggling to rise without help. Now developed a head tilt, vomited once. The owners report she's quieter than normal, no known trauma. And so mentation is mildly depressed. She is I'm sorry, I'm moving that up on you. She's non-ambulatory due to pelvic limb weakness, but maintains good thoracic limb strength. Can support the front end when assisted. Pulse reactions are absent in both pelvic limbs and normal in the thoracic. A left head tilt is present with horizontal nystagmus that can change direction with head position. Cranial nerve examined shows decreased palpebral reflex and mild facial paresis. Pupillary light reflexes are normal. Menace response is present. Everything else appears good. Gag, though, is reduced. Tongue function and strength appears symmetric. Spinal reflexes include increased patellar reflexes, normal thoracic limb reflexes. I gotta move my pointers. Reflexes are increasing the pelvic limbs, normal in the thoracic limbs. Pelvic limb may be increased in terms of tone. Cutaneous trunci is reproducibly absent. Caudal to the level of the last rib, tail tone and peroneal reflex are intact. Deep pain perception is present in both pelvic limbs, and mild pain on thoracolumbar patient with no cervical hyperesthesia appreciated. How would you neurologically localize this patient? I definitely think there's a left central component. Yeah, and I think the best terminology for this particular case would be multifocal. Yep, plus T3L3, exactly. And so I think you could say, hey, this is likely to be brainstem, right? I think there's more of a support here for vestibular disease. Again, I think you could argue bilateral, potentially brainstem, with left being worse. The then the T3L3 fits, right? The cutaneous trunci actually supports the T3L3. Now, real quick, let me tell you about cutaneous trunci. Cutaneous trunci is only a useful reflex when it agrees with me. If it disagrees with me, it's trash and we should ignore it. If it supports my theory of what's going on in the dog or cat, then it's the best reflex we have and we should trust it till kingdom come. All right. And again, it's just one of those situations where it has its pros, it has its cons, but I will never wear my hat. Wear my hat? Hang my hat? Hang my hat. I knew there was an expression there. I'll never hang my hat solely on cutaneous trunci unless I have something to back it up. And so to me, cutaneous trunci is always additive. In this case, it was additive. It was great. It told us exactly where we had this. And so this is a great example of multifocal disease. This is a dog that had meningoencephalitis of unknown origin. All right. This is a dog that had both myelitis, a little bit of meningomyelitis technically, and then brainstem focal area of encephalitis. All right. And so when you see those multifocal limbs, again, just a great thing. Don't get too caught up and be like, well, it's technically here, it's technically here. Y'all, if it's in two locations, just say multifocal. Don't make it too hard. And it's funny because I think people get caught up in like, okay, it's got to be one. It's got to be one. Well, in first year of vet school, it is one. It's always one lesion in the first year of vet school, right? And second year, we dash in again, depending on where you were trained in your instruction, we'll dash in some of these multifocal things. But reality is, a lot of times, some of these diseases are multifocal, right? Especially Chiari, meningoencephalitis. Like they have issues where you can have a primary lesion in one spot and a secondary lesion in another. Or for meningoencephalitis, right? It's just multifocal. And when we have myelomalacia, right? It's going to be diffuse. It's going to start maybe at that T3L3. By morning, your cutaneous trunci is up here at T4 saying T3L3, but now your reflexes are decreasing L4 down to S1. If your perineal reflexes are affected, then it's down to S3, right? And so now all of a sudden now it's diffuse because it's all connected. And that's the difference between multifocal and diffuse. Diffuse is all connected. Multifocal means that there's normal tissue and normal function in between the regions we have disease. Oh, this is a nice little short one. All right. 3 to 4 weeks of reluctance of jumping and climbing on the stairs with pelvic limbs. Weakness followed by rapid worsening over 3 days. Urine dribbling, reduced tail wag, appears painful when rising and when the tail is lifted. Mentation is normal. Ambulatory with paraparesis in a crouched pelvic limb posture. Thoracic limb gait is normal. Posture reactions are delayed in both pelvic limbs and normal in thoracic limbs. Cranial nerve exam is normal. Spinal reflexes in the pelvic limbs are decreased and with reduced tone, while thoracic limbs are normal. Perineal reflex is normal bilaterally with normal anal tone and normal tail tone. Please localize this lesion as specifically as possible. Remember, this is a safe place to learn, so it's okay to take a shot. There's no judgment. Yeah, I love it. So L4 to S3. Now, this is where someone can come in and be real pedantic, right? By definition, L4 S3 is a perfect answer. On your board exam, it's probably perfectly fine. If I want to be pedantic, I would say technically S1 to S3 is intact, right? And this is one where people are like, oh, this must be lumbosacral disease, right? Because it's a German Shepherd, but then like the limbs are more affected than the anal tone. And you're like, well, how does that make sense, right? So this is probably better a spinal cord lesion in a German Shepherd, whereas like I would like to see both a little bit of like decreased tail function if it was a little bit further back in that LS region, right? Maybe the limbs aren't as affected, though they can be, right? And this is a good one because I love this case. This was a case that had a freaking meningioma back at like L4, 5, 6, and then like the tip of the spinal cord was perfectly fine. And so again, if they wanted to be pedantic, they could be like, well, there's L4 to S3 and there's L4 to S1, which is most specific, right? Now that'd be a real jerk move. But technically, the L4 to S1 would be the most specific because our anal tone and all that's normal. And again, that's just being a little pedantic. And then, the same thing can happen if we have an LS case, right? Now it's just going to be the anal tone. The pelvic limbs might be normal because that's more the cauda equina and not necessarily the spinal cord. Whereas this particular case was the spinal cord proper. Good job. Thanks for taking a chance. I appreciate it. So we got a 7-year-old Great Dane, 1 month history of when playing. Starts walking normally, but within 5 to 10 minutes becomes progressively weak. Sits, leans, improves after rest. Mentation is normal. Gait is initially normal, but after repeated sit to stand and a short hallway walk, develops generalized weakness, tendency to collapse. Coordination is appropriate, and there is no true ataxia. Posture reactions are normal when tested. Cranial nerve exam is already normal, but has an intermediate fatigable palpebral reflex. The other ones are all kind of normal. Jaw tone and gag are normal, and spinal reflexes are normal, no spinal pain. Where do you guys localize this one to? Yeah, this is a great classic neuromuscular. When we talk about neuromuscular conditions, I'm going to raise myasthenia gravis on this one because the proprioception is normal. It's the one of all of them that tends to have normal proprioception until we actively fatigue these animals. And you can see that we have that fatigue of that palpebral reflex, nice little additive type thing that's like, oh, yeah, yeah. And that tends to be present when we have these patients, especially if they're kind of in that generalized myasthenia. So this is a great little myasthenia neuromuscular case for you. Case 9 here. 2-year-old male neutered mixed breed dog, 2 days of pelvic limb weakness, progressed inability to stand, worsening thoracic limb weakness over the next 24 hours, was out running with the cows. Now he cannot rise. Owner's worried about a spinal fracture. No pain was reported, however. He's eating and drinking with assistance. So, non-ambulatory tetraparesis, tetraplegia, decreased muscle tone. Posture reactions cannot be reliably assessed due to profound weakness. Cranial nerve exam is normal, including menace and pupillary lights. Normal gag and tongue strength, no nystagmus, no strabismus. Spinal reflexes are markedly decreased to absent in all the left thoracic, right thoracic, left pelvic, and withdrawals weak to absent in all limbs. Superficial pain sensation is present in all limbs. No spinal hyperesthesia appreciated. Muscles are not painful on palpation. Tail tone is reduced, and the peroneal reflex is mildly decreased but present. So where's this dog localized to? And there are technically probably two correct answers. Yeah. So I think the top one for me is neuromuscular. And I think polyridic is a fair one. Botulism is a fair one, especially on a dog that's running around 40 acres. Who knows what died out there, right? I think it's a little fast for polyridic. But it all depends, right, on what these owners really are reporting, right? Because like if he's running around 40 uh hours or 40 40 acres, there's a decent chance, right? He may not be like as watched as they think he is. But again, we don't know, right? And so yeah, I think some sort of junctionopathy. I think polyridic, any of our lower motor neurons is on there, tick is on there. This would have to be a fulminant myasthenia. There's a couple of things that just don't quite necessarily fit with that, but it doesn't mean it couldn't be. But it would have to be like a fulminant. But this particular case actually was a botulism case that we had, and the owner really did not. He thought he knew his dog. He did not. He had no idea what the hell his dog was doing. So this was botulism. That was supportive care, and he got better. Or at least we assumed it was botulism because we did actually send out the test because he was a bit of a jerk. And final case, threw in a cat, right? Had to not forget our kitties. All right, acute onset of head tilt, falling, rolling with one episode of vomiting. Appetite decrease since onset, no toxin exposure. Left pupil looks a little smaller, and the eyelid seems droopy. Mentation is depressed with reduced responsiveness to environmental stimuli. Non-ambulatory due to severe imbalance and rolls and falls to the left. Left head tilt is present, and nystagmus can be elicited that changes direction. Posture reactions are decreased in the left thoracic pelvic limbs. Left thoracic, left pelvic, and are normal on the right when she's supported. Sorry, I wrote that weird. Cranial nerve exam reveals left facial paresis with reduced palpebral reflex on the left, and findings are consistent with left Horner syndrome. Gag is intact. Tongue strength appears systemic. Spinal reflexes are normal and systemic in all limbs. Symmetric, sorry, in all limbs, and no cervical pain. Where would you localize our cat to? This is a 10-year-old, not a kitten by any means. Yeah, I think this is a beautiful classic case of left central vestibular. I would argue, well, here's what's funny. What we don't ever do is we never say, hey, this could be multifocal. Like we don't parse out, right? peripheral, vestibular, and central, but like there are evidence that this has a peripheral component, right? And so that Horner's has a higher association with peripheral because of its association with the external ear canal and how it kind of runs through that bular region. And so it's just interesting that like technically, right, this should be a multifocal cat. Like it technically should be peripheral and left central. And my story there is that this cat has an ear infection, likely, that then has invaded into the central brainstem. And that's exactly actually what we ended up finding. But it's weird that we always take the more severe form, but we never are like, oh, this is peripheral and central. But that's exactly what this cat was. And so it's one of those like redundancies, right, in neurology where you're like, well, yes, technically we could say it, and maybe we should, but at the same time, you're like, well, it's also left central, and that is worse, in terms of, again, as we talked about earlier, the diseases that are associated with that, right? Like that's the more concerning part than the peripheral stuff, right? So, just something, one of those things that if you had something like this, they could not put multifocal or and be and left central and be correct. Like all of those would be correct, but always do the worst one. And so I think left central was the textbook answer. Left central with evidence of peripheral involvement would be the more cleaner, polished, professional, in my opinion, answer. Well, y'all, thank you for playing with me on these 10 cases. I do hopefully I highlighted some different scenarios for you that maybe you haven't necessarily seen in clinical perspectives, or if you did, you're like, oh, never quite, I forgot about that one. Kind of our central cord syndromes, things like that. Any questions that y'all have at this juncture?